what's new in these gold recommendations?
But I think what people have to probably remember from the main change is the approach, okay, to the treatment, the management of COPD, where we now separate the initiation of the treatment, where patients are still classified as A, B, C, D, according to symptoms burden and risk of exacerbation. But when the patient is reassessed, meaning that the patient is already on a treatment, or you're seeing the patient that has been treated by someone else, we're still looking at symptom burden and exacerbation, but the patient will not be classified A, B, C, D anymore. He's going to be looked at being mainly patient that has personal trait of dyspnea or personal trait of exacerbation. And then there is a whole recommendation based on evidence now from different studies such as IMPACT, such as FLAME, and also based on a biomarker blood eosinophil, where we are going to escalate on the treatment. Occasionally we are going to de-escalate, occasionally, okay? And always reassess the patient to know if he has response to the treatment, and if he's still symptomatic, why would it be? Is it because the patient doesn't take his medication, adherence, or the technique of the inhaler might be a problem? And also consider the non-pharmacology treatment, such as pulmonary rehab and self-management education, and then readjust the treatment. Then there is now a whole loop that is continuous in assessing the patient. Then, okay, after that evaluation, making adjustment to the treatment.
So is now clear recommended the triple therapy from some patients. Which patients can have more benefits from this approach?
It appears from the IMPACT study, that is for now, the study that had really is a landmark study where patients that have severe exacerbation, such as those requiring to be hospitalized or recurrent exacerbation, would benefit of triple therapy when you compare to duo therapy, either ICS-LABA or LABA-LAMA. But on the top of that, patients that have high blood eosinophil and the threshold certainly of 300 would appear to be the top of the continuum relationship between blood eosinophil and response to ICS, would be those who seems to respond the best. On an individual basis, what are we going to do? I think we have to be careful. There may be some patients that are still going to be considered to be on triple, although as a general rule now, what we are proposing in GO, based on evidence, it's recommendation that should help the clinician to guide their treatment and avoid also patients who shouldn't be on ICS, because triple therapy is not for all.
So should we take the risk of pneumonia to reduce the risk of exacerbation?
There is always a risk in giving a treatment, and we know that. That's the way medicine is practiced. It is the way we practice for any disease. The risk has to be known, and with ICS we know there is a risk for pneumonia and other side effects, by the way. Why have we focused so much on pneumonia? It's because we are able to measure pneumonia, but there are other side effects, by the way, with ICS. And it's always a balance. We have to be able to take a decision where we would likely, in a given group of patients and for a given patient, decide to go with one treatment where the benefit will likely outweigh the side effect. It doesn't appear that patient died from pneumonia, and that is reassuring. Does it mean that we shouldn't care about pneumonia? Absolutely not. We have to care.